Welcome, everyone. I'm sorry that we're starting a few minutes late. This is Christine Toriason at FHI 360. I see a number of people joining the meeting. We had a few technical glitches, but we're glad to have you here. We're just going to give a few moments for everyone to get online, and I hope that you can see the slides on your screen. Okay, so I think we're good. So once again, this is Christine Toriason from FHI 360 and the Options Consortium, and I'd like to welcome you all today to our virtual PrEP Learning Network. We are going to talk today about PrEP integration, and our primary focus will be on integrating PrEP with family planning services. Could you show the next slide, please, Mila? So this is the overview of our program today. We had originally planned to also talk about PrEP and STI integration, and we don't have a presentation on that, but I think there are some people on the call who have experience with that, so if that comes up, we will have the opportunity to discuss amongst ourselves. But for today, what we do have is an overview from USAID about, particularly from their, not just from the HIV experts there, but from the reproductive health experts talking about what is similar and different and what would it take for services. We'll also hear from the Power Study in Kenya, looking at a implementation study at an integration model. And then we're going to hear from our colleagues in Zimbabwe, where they have actually done a pilot of integrating services in the public health sector. Moving on to the next slide. These are our speakers today, and I will introduce them as we go into each presentation. Can I see the next slide, please? I just want to do a little bit of housekeeping for the call. We did have a little technical glitch. That's why we're starting late, so my apologies, but here we are. If you do have any technical challenges, please shoot us an email, and we'll try to help resolve them. We have a chat feature. It should be at the bottom of your screen, and we think that the chat can be is a very useful way to sort of share thoughts, ideas, questions, or your own experiences. So when you go into the chat, there is a toggle button for the to where you can select who to send it to, and we ask you to share your chats if you're comfortable with everyone, including sometimes it says participants, panelists, and attendees. So that allows everyone to see your questions or comments or feedback. So moving forward to the next slide, we will get going with starting with our presentation from USAID. Next slide. I'm going to pass this over first to Robin Akel, and then she will pass it on from there. Robin, over to you.
Hi, thanks, Christine, and hi, everybody out there. I'm calling in from a somewhat chilly DC, and hope you all are having a great day so far. I'm actually filling in for Nithya Mani, who was going to present the first few slides here, but was called away last minute. So I hope to do these first two slides justice, and then I'll pass off to my colleague, Jen Mason. Next slide. I should say that, first of all, we're really excited to be talking about integration of PrEP and FP services, but we acknowledge also that this is just one opportunity for service integration. Like Christine mentioned, there are also opportunities with STI programming and other avenues as well. So we're just talking about this as an example of integration and an area that we're particularly interested in. But why are we considering this? So I think many of us, or probably all of people calling into this webinar, have examined the ECHO results closely, and which showed high rates of HIV and STIs among AGYW, and that there's still a high unmet need for FP among AGYW. FP may also be a preferred entry point for HIV services. We've seen this through DREAMS, It was articulated through ECHO results. We've also heard about this from other scoping research that happened in the earlier days of PrEP. So this is something we want to take seriously if women are asking for it. There's also a potential need for increased uptake of both FP and, there's a potential for increased uptake of both FP and HIV prevention services. And then we want to improve overall reproductive health counseling and adherence and reduce discontinuation of both contraception and PrEP. So if these two things might strengthen the other. There's an opportunity to reach AGYW through innovative platforms, both for PrEP and FP, and leverage multiple demand creation efforts, and reposition AGYW reproductive health services. We're also looking at this as an opportunity to reduce stigma and increase the notion of female empowerment. So next slide. Oh, sorry. FP stands for family planning. Thank you for that question. Please feel free to jump in with any others there in the chat if I'm speaking too quickly or need clarification. So USAID is actually considers PrEP and family planning two of our high priority technical areas. And we also have significant programming in both. So this is a great opportunity for us as an agency, as well as with our, for our partners. And just to talk a little bit about both areas. So PrEP is a rapidly growing technical area and intervention for us. We've gone up by 99% in our PrEP new targets from our COP18, which just ended, into the current COP year, which just began. And this programming continues to grow. We expect it to grow in the next couple of years significantly. But there are still huge deficits in PrEP knowledge and awareness among potential users and the larger community and providers. So we're looking at any opportunity to increase knowledge and awareness about PrEP and eventual use. Opportunities to increase awareness and meet demand can be found through service delivery.
Robin, we just lost you. Is anyone else hearing Robin?
Nope, not at this point.
I know she had some audio challenges earlier. Do you think we should just pass it over to Jennifer?
I can do, I'm fine to do that. You guys can hear me, right?
Yes.
Yep.
Okay, so hi everyone, good morning, good afternoon. This is Jen Mason from USAID. I'm the Senior Advisor for Family Planning and HIV Integration in the Office of Population, which is USAID's Family Planning Office. My colleague Robin dropped off, but I'll jump in, finish up the slide. So Robin was talking about that both PrEP and family planning are key priority technical areas for USAID. PrEP, of course, is the key element of our PEPFAR programming, and then family planning as the USAID's Office of Population's priority area. Just to let you know, USAID is the lead U.S. government agency for family planning and is the largest global donor for family planning technical assistance, and then the second largest donor for contraceptives, with UNFPA being the first. USAID PRH priorities is that all women have access to high quality voluntary family planning with a focus on women that are underserved, which of course includes adolescent girls and young women who have some of the lowest rates of family planning access globally. So we, as well as our colleagues in HIV, work very hard to increase access to services for adolescent girls and young women. As an average, 21% of women in sub-Saharan Africa have unmet need for family planning, and that is significantly higher among adolescent girls and young women for a variety of reasons that we can go into, in the question period if you want. USAID, as well as many other donors, many other organizations in the world, have developed extensive tools and resources to help guide integrated family planning programming, family planning integrated with maternal child health, but also family planning integrated with HIV. We don't have a lot of experience so far with FP PrEP, but we are certainly learning, and we are extremely excited to have this opportunity to share what we know and to be on this panel, and also to hear from all of you regarding your experiences with FP PrEP integration, because this is an area that we would like to learn more about and develop resources and tools to help our partners in the field move this activity forward. Next slide, please. FP and PrEP programming considerations. So as people consider whether it's a good idea, whether it's a smart option to integrate family planning and PrEP, there's some key areas that we would like partners and to think about. And that is that, so those of you familiar with family planning programming, you know that family planning is focused on volunteerism and informed choice, which is not, it's not to say that PrEP is not focused on that area, but for family planning, our criteria and policies are very specific. So that's one thing to keep in mind as you're considering whether to integrate. The other thing is that pre-screening and education for family planning clients and PrEP clients may be different. It may be similar, but it is something that needs to be reviewed. You would need to look at screening tools, counseling and education tools, and see how those can be integrated and combined. Another area to keep in mind is the record keeping and PEPFAR reporting. Of course, for regular family planning, we don't do PEPFAR reporting because that's not required for us. Also, record keeping for family planning is probably a little on the let's say, lighter side than it would be for PEPFAR activities or HIV activities in general. So it is important to think about how record keeping will be done for an integrated service, and keeping in mind the burden of reporting. Another area to consider strongly is the follow-up and adherence and monitoring that may be required for PrEP clients. In general, family planning clients are not followed up. There is not a concept of adherence or client monitoring for family planning. So that would be a significant difference in the role of the health provider or the health service if PrEP were to be integrated into family planning programming. Another area to consider is commodity management, and I think that's just one where the service delivery sites will need to figure out how best to offer commodities for the client. Usually family planning commodities are offered in the room where the service is provided. For PrEP, that may or may not be the case, but that would be something to look at, how to ease the service flow for the client, potentially by offering both types of commodities in the same space. Another area to consider are the revisits for clients. Sometimes family planning clients do not need to have revisits. If they choose to use a long-acting method, they may not come back to a clinic for several years. So that would be an area that needs to be considered. But on the other hand, there are short-acting family planning methods like oral contraceptives, condoms, injectables, where the client may be coming back every month or every 3 months, where that could fit very nicely into their PrEP revisit schedule. Referrals are another area of consideration, just in that whether the client may need to be referred within the facility to get different types of family planning services or to get their PrEP medication, or if they need to be referred outside of the facility. Next slide, please. So we at USAID, we have done a lot of thinking about the opportunities for PrEP and FP integration, as I know many of you on this call have as well. Our colleagues at WHO and UNFPA, as well as UNAIDS, have also been thinking a lot about integrating PrEP and family planning. So here are some ideas that we've come up with in terms of near-term, longer-term, medium-term as well. So in the short term, some opportunities that may exist is to support differentiated models of FP PrEP integration. And we listed several there, and these are models that many of you are familiar with. If you have questions about any of these types of models, please let me know. These are really based off of family planning service delivery models. So these will be places where we normally have family planning service deliveries where there may be an opportunity to integrate PrEP. There also is an opportunity to look at bidirectional or cross-element demand creation efforts. So as projects are doing either demand creation for family planning or HIV, they could integrate the other element and work on something that would be more of an integrated package for the targeted population. Of course, like I described before, co-dispensing of family planning and PrEP commodities at the same site. The other thing is to consider, of course, as everyone knows, when we design these interventions, to plan for monitoring quality and the outcomes of the program. And when I say outcomes, I mean both the PrEP and the family planning outcomes. Medium-term activities could be something sort of training opportunities, building capacity of FP and PrEP providers to offer dual services. That would be things like helping to work with them on conducting risk assessments, counseling, data collection, using job aids, and making referrals. Another area of great interest to us is how to integrate PrEP screening into the HIV risk assessments that are often implemented by family planning providers in high burden HIV settings. Next slide, please. So next slide, we talk more about medium term, where we talk about adapting HIV and FP data collection tools, LMIS and HMIS tools, to ensure that the reporting of both services is done accurately and timely. Currently, for family planning, we mostly use a family planning register. In many sites, there's also forms and so forth to track service delivery and LMIS issues. So there may be a need to integrate those so that all of the information is aggregated appropriately. The other thing to consider is to provide technical assistance to HIV and family planning units in our host country government partners to ensure that the national guidelines and standard operating procedures on PrEP are designed with a women-centered approach, including access to voluntary family planning. The other thing is, like I said before, is considering whether dispensing PrEP and FP products is feasible. Some countries are looking at the co-packaging of products, which would mean that you sort of pack them at the pharmacy level and you offer them to women in a package. Another thing is where that could be done at a regional or district warehouse. There are some limitations for that type of activity, given that some family planning methods cannot be dispensed over the counter. They would have to be, injections or implants or IUDs could not be provided that way. Next slide. So longer term activities, which these are ones that we see as, probably in the distant future, but things for people to keep in mind and to consider is, of course, monitoring the quality of the services over time, making adjustments to improve outcomes, and of course, measuring client satisfaction with these integrated services, having a long-term plan for the scale-up of PrEP FP integration, figuring out what the long-term objectives for each service might be and how the integrated service helps to achieve those outcomes, figure out what resources may be needed, and then also look at the clients and determine what the client's needs are and how these integrated services may suit them best. A question that has come up quite a bit in our discussions is, will women who continue to use PrEP but don't need family planning services continue to access PrEP through family planning? It's just a discussion question, but something that sites would have to think about for the long term of this type of integration. The other thing would be in the long term, as new multi-purpose technologies come available, consider piloting those new prevention tools. Next slide, please. The other thing, so of course, I'm from the Office of Population, as I said, and our colleagues here at USAID, they fully support. We don't want to forget the family planning part of PrEP FP, which is, to remind everyone that PEPFAR funds can be used to support family planning activities, but they cannot be used to procure contraceptives. When we're doing this type of integration, it should benefit both PrEP and FP services, as Robin said at the beginning. We want to leverage and collaborate with existing FP platforms and activities. So that means for our HIV colleagues to reach out, be collaborative with the Ministry of Health Family Planning Division, also work with your USAID or other government colleagues when possible. Here's my contact information, also the contact information for Nithya Mani, who was unable to be on this presentation today, but Robin is very available and she's our PrEP expert. We have our last slide is the references we use for this presentation. Thanks so much. Now I'm handing over to Jacqueline.
Well, actually, can I just jump in, Jen? Thank you very much.
Sure. Oh, sorry.
So I just wanted to, this was a great overview, and I think it really highlights some of the potential benefits and challenges of integrating PrEP and family planning services. I want us to move into the next presentations, which talk about some experiences doing that, which will get at some of the questions being asked about how it's being done. But I am interested in having folks on the chat, respond to what extent are these services being co-delivered in your setting right now? I think we're trying to get a better handle of to what extent is this already happening, and to what extent are more resources needed to be invested to expand this area. So with that, I will then move on to, I think it's Josephine. Next slide, Mila. Josephine, I know you were having some sound issues. Are you there? Okay, I am seeing Josephine on, Martha, but I'm not hearing her. Okay. Yeah. It's very garbled and we can't hear. So I'm going to propose that we actually move to Gertrude and the Zimbabwe team to their presentation. And in the meantime, maybe Mark will call out to you and get a better, clearer line. Gertrude, is that all right with you?
Oh, it's okay. Thank you so much. Thank you. Afternoon and morning to everyone. We are going to share learnings from integrating oral HIV pre-exposure prophylaxis in public family planning facility and youth center in Zimbabwe. And this was an exercise assessment which was done January 2018 to June 2018. Next slide. So Zimbabwe is one of the countries which has actually started implementing PrEP. And when we got the guidelines from WHO, we said we're going to do it in a phased out approach. With that phased out approach, there is like the DREAMS districts, but there were facilities like the family planning facilities and the public health institutions where we did not have a lot of resources to start pre-exposure prophylaxis. But what we did now to learn lessons to say how should we roll it out, we actually got funding from CHAI where we said let's look at how we can integrate pre-exposure prophylaxis into family planning sites. So we had 2 sites which we actually looked at. This first site was a site which is already a family planning site and which is providing VMMC. And then the second site was a rural site where it's a youth center where we are getting a lot of youth people coming into that facility. And if you look at pre-exposure prophylaxis, we actually say it is for the high-risk people. And looking at our epidemic in Zimbabwe, we realize within the young people, the HIV incidence is high. So for the objectives of this presentation, I'll look at feasibility of integration in a real world settings and as well as effective strategies that can be used and the overall lessons learned in integrating PrEP into family planning settings. Next slide. The next slide is what I have been describing, that we looked at an urban site and at a rural site. The urban site was a family planning site, which was already providing VMMC services and contrast and family planning services. This rural site was a rural youth center, which is an integrated site, which is providing HIV prevention, treatment, care, as well as family planning services. Next slide. So what we learned from these 2 sites, the majority of the people who were tested negative and who were at high risk, we look at like the females in those sites actually were initiated on pre-exposure prophylaxis. Almost about 5% of the people who were initiated were females. And if you look at males, it was again within the age groups of 16 to 24 years, and it was 1.3% of those who were initiated, who were negative, which were males. So if you look at this age group, we're saying it's a reproductive age group, which is at high risk. And we felt, and most of them, they frequent our family planning sites. And we felt it was very important actually to integrate services within such kind of settings. So what is it that we learned? Next slide. looking at the healthcare workers first, because for us, for a program to actually succeed, we need to capacitate the health workers. We realize that educating the health workers and understanding the benefits derived from tying pre-exposure prophylaxis with family planning options for clients allows not only adherence, but monitoring, because these are the clients who frequently come in for reproductive services, as well as like for reproductive services, and then we add on HIV prevention services. And then we realize that for the facilities, the health workers providing much needed training in both HIV and family planning to the health workers help facilitate integrated counseling. Because if you look at family planning, when we are initiating someone on family planning, there's a counseling, and even for PrEP, there's risk assessment and all that. That counseling, if it's integrated together, you'll be able to say, oh, this one maybe is at high risk, and then when it's at high risk, then you initiate a pre-exposure prophylaxis, and they are testing negative. Because in all our family planning centers, we are actually testing for HIV for those who are actually coming for family planning. So it was a good opportunity to integrate these services and talk about pre-exposure prophylaxis. And then we realized that integrating that, it will minimize documentation, or combining those required for PrEP allows further integration of PrEP and allows health workers to focus on the client who is HIV negative, who is at high risk, and who can benefit from pre-exposure prophylaxis. Next slide. What were the barriers which we faced with the integration? As I said before, some of the sites, the other site was solely looking at family planning and voluntary medical male circumcision. The other site, there was an integration of services. We realized that where we had already integrated the services, it was easier for the health workers to integrate pre-exposure in those sites, because they were already providing HIV treatment and care, and even the issues of counseling, because with HIV treatment, there was already counseling, adherence counseling and all that. But in the site where there was only family planning, which was being provided, we had actually to train the health workers into HIV prevention and treatment. So there was really a difference between those two sites. And then we realized even the monitoring and evaluation tools, data collection tools which were being used, where there was already integration, the data, it was easier actually for the health workers to grasp the data collection tools. But where there was only family planning, which means family planning, the data collection tools did not have the HIV component in that. So we looking at that, those were some of the barriers. And even demand generation, when you get into that site which was integrated with both family planning and HIV prevention, the education, when a client comes in, the health education, like we will talk about HIV testing, and then we say with HIV testing, those who test negative, you have got chances of getting pre-exposure prophylaxis for those who are at high risk. So it was easier for them just to flow that health education to flow to those already in an integrated site. But in a standalone site, which was mainly family planning, it was a bit difficult. So we looked at how best we can look at the tools, and then look at our health education given when the client comes in, so that it ties both to say, if you are HIV negative and you are at high risk, with all that risk assessment, then we can initiate you on pre-exposure prophylaxis. We realized again in the site where it was integrated, like it was the rural site where there was integration, there was this barrier of saying, maybe when there was a time when they got this stock out of HIV test kits, which I think when we look at an integration. Sorry, am I too fast? Hello? Okay,
No,
I think on the commodity supply as well, in an integrated site, all the commodities will be available. But in not an integrated site, like for the HIV test kits, when they run short, they will just even not actually commence people on pre-exposure prophylaxis, because one of the requirements for pre-exposure prophylaxis was to have what? An HIV test, and you test negative. Next slide. So program experiences, like maybe if we are looking at integration to already what I've already alluded to, we are looking at combining the data collection tools, and this reduce the health worker burden of reporting and works in improving data accuracies to inform decision making for both services. And then if we synchronize commodity supply, clients receiving commodities at the same time helps in improving adherence and in managing the stocks to prevent stockouts for clients who are coming for services. And then integration of training. I think this one is very important. Like our trainings have been siloed, but then if you put family planning as well, where we talk of HIV combination, HIV prevention, then, and we talk of pre-exposure prophylaxis, the nurse will actually, or the health workers will be able to actually provide those services. And then the demand generation efforts, like when we saw in the family planning sites, which was only family planning, it was only siloed to family planning, the demand generation activities. Even the job aid which was there, it was only talking of family planning. But in the area where we had integration, it was actually easier to actually have PrEP being initiated in those areas. So those are the strategies which we say, which we actually realized within that 6 months of piloting integration of family planning and pre-exposure prophylaxis in those 2 sites which we were piloting the services. Next slide. The next slide is for the lessons learned. Training of health workers on both PrEP and family planning will be cost effective, save more time, will actually capacitate and give the health workers time to talk about both pre-exposure prophylaxis and family planning. Having combined M&E tools, someone must not, maybe in that room, wherever is consulting, cannot go out and say, okay, let me go and get from the family planning center where they are providing family planning services. But it will be sort of like a one-stop shop where everyone will actually be able to put the data which they've, when they are actually looking at that client. And then allowing clients to acquire their family planning commodities together with PrEP is improving adherence for some clients, because both for family planning and for pre-exposure, there's risk assessment, there's monitoring, there's counseling and all that. So it will allow that. And having the HIV risk assessment tool utilized within client counseling for family planning helped to identify, helped in identifying clients at high risk and created opportunities to have PrEP counseling to occur. So those were these lessons learned. And maybe in conclusion, I will just say integrating family planning and pre-exposure prophylaxis, I think is feasible and it's very much cost effective, provided we do capacity building, provided we provide all the tools of trade for the service providers who are actually looking at those clients. And then I think my last slide, next slide. I would like to thank all the people who participated in that, and like Chai for providing us the funds, the UK Aid, Zimbabwe National Family Planning. Now, when we're actually writing our implementation strategy for pre-exposure prophylaxis, it actually enabled us to say, we will actually be providing pre-exposure prophylaxis within family planning settings. Thank you so much. I'll hand over to the facilitator.
Thank you, Gertrude. I think we should pause for some discussion because there are a number of interesting questions that have come, and then we will go over to Josephine after we have some discussion. So, Gertrude, I think this was basically a pilot in Zimbabwe that was meant to inform the likelihood of broader integration. Yes. Some of the questions that have come through are around, well, one is how do you integrate long-acting reversible contraception or longer-acting contraceptive methods? So really I think what you're talking about is a co-delivery in a site, but not necessarily that at every visit the client is getting both PrEP and family planning. Could you talk a little bit about what the logistics of that look like?
Okay, like already we've got the family planning product. And when the way we are saying we are integrating, we are saying the service to sort of like be provided at the same place. Like I talked about the Family Planning Center, which was not even providing any ARVs or any ART medicine. But we are actually saying we are faced with a client there who comes, and then this client is testing negative. And then when this client is taking negative, and then you cancel, if this client is at high risk of getting HIV, you are able to provide pre-exposure prophylaxis. And we don't just provide even contraceptives. You need to screen those clients. Is that client eligible for pre-exposure prophylaxis? Is that client eligible for family planning if he's coming for a family planning? Because not all the clients who are coming for family planning are coming, maybe some are coming with infertility issues and all those things. But so we are actually saying we screen that client. If he's eligible, if he's not contraindicated PrEP and the family planning products, you are able to give that one.
Hi, this is Jem Mason, can you hear me?
Yeah.
Hi, so just to add on to that question or comment, I think it's a really important one to think about because in many countries, more and more women are choosing to use long-acting contraception. There's still most countries in sub-Saharan Africa where HIV incidence is highest. The use of short-acting methods, particularly injectables, is still the highest proportion of contraceptive use. However, there are shifts in the use of contraception. And I think it is important to think about clients who want to use long-acting methods and how they would be able to continually access their PrEP if they were using PrEP for a longer term. Of course, when a client initiates a method, if they were getting an IUD or an implant at the facility, that could be an opportunity when that happens. For them to receive PrEP and then to be initiated into PrEP and to have a discussion about revisits and follow-up and so forth. Clients who use short-acting methods like injectables, they could come back every 3 months and get a refill of PrEP potentially at that time. Clients who use oral contraceptives, depending on the schedule for the country, may come back every month, may come back every 3 months, it depends. So there's some opportunities for sort of a real synergy with PrEP follow-up. For long-acting methods, that may not be as easy or as sort of synergistic. Those clients may want to get their PrEP refills somewhere else other than the family planning site because they don't need to come back to the family planning site. However, I mean, that's really up to the site to figure out whether the family planning site wants to become a long-term PrEP dispensing site. So that would be something at the country level or at the site level that they need to figure out. Is it effective in terms of client flow, service delivery, cost, et cetera, for that site to become a place where a woman who's not actually receiving family planning services on that day is still able to receive PrEP services. I'm not sure if from Zimbabwe or the other countries, if people have had experience with looking at PrEP delivery in a family planning site over the long term and what that might look like, but that's a really interesting question that we still haven't seen a lot of data or evidence for.
So very good points, Jen. And I think, another question that came up was, does this co-delivery help support adherence or continuation? And I think that is still an open question, an unanswered question. And one that when we hear about the power study in a few minutes, we'll hear a little bit about what they're finding. Another question that came through, had 2 other questions that came through, Gertrude, had to do with how did you integrate the training? Did you do a separate PrEP training, or was there an integrated PrEP and family planning training? And also, what type of monitoring and evaluation tools did you integrate this pilot?
Okay. On the training, like on the family planning side, they were already trained for the family planning. And then the integrated training which we trained was sort of like training on PrEP and how, like they were not even dispensing any PrEP medicine. They were only dispensing family planning. So that was the training which we actually looked at, where we're saying the family. But on the other integrated side, it was really the PrEP training because already they were dispensing like already ARVs, and then it was just an added training for those ones which were at the integrated site. Already they were dispensing even family planning products. This is what you say. And then on the M&E tools, like PrEP was actually a new product to us. We're still piloting it and we're still looking at the demonstration projects. We did not have any data collection tools or any indicators for pre-exposure prophylaxis. So this is what we actually integrated. And my colleagues can respond, the child colleagues.
I think just to add on to that, hi everyone, my name is Patrick. One of the things I wanted to highlight in terms of integration of M&E tools. So for example, like we mentioned, the risk assessment tool that was being used was developed specifically for PrEP. And that's one of the M&E tools we utilized within family planning counseling settings to be able to help identify those in high risk within family planning sites in order to inform PrEP data that we could utilize in terms of analysis and decision making going forward, which then informed the actual PrEP implementation plan being utilized within Zimbabwe.
And another question has to do with how did one of the challenges is always providers are often already overworked and perceive that they have a heavy load. So what was the reaction of the staff to adding this additional piece of work? And are there any key factors in terms of sort of the level of commitment or buy-in that you received that helped motivate them?
So one of the things that came out clear from our healthcare worker interviews was that at the point in which they were being educated about PrEP and being more familiar with it and then realizing the benefits that it had for clients, we had a more positive attitude and a more positive reception that came through from the healthcare workers regarding providing PrEP within their sites, knowing that there'll be slightly increased workload regarded in terms of now reporting. So that was one of the key things that needed to be done in terms of when you're addressing the healthcare worker, it's imperative to have the healthcare worker be also aligned to what you're trying to do, not just from a workload point of view, but from an attitude point of view, which helps in terms of driving them to do the work. So that's probably from my end one of the key things that I would want to put forward there. Though in other settings, you can have situations where healthcare workers may not be too happy, but like I said, it's about ensuring that you're making it clear the benefits that it would be for clients.
And so a related question is, how long does it take to complete the risk assessment tool and the counseling? How much overall time did this add to a given visit?
So this varies. You can have situations where it can take 2 to 3 minutes because of these are conversations being had. You pick up some of the information as you're talking to your clients. Some, if they're really going deep and taking their time, they could probably go up to maybe 10 to 20 minutes, depending on the conversations being had.
So it is a substantial chunk of time when you consider the client flow, but not to say it isn't important. Another question was around commodities. So I think one of the challenges is if a country doesn't already have family planning clinics stocked with HIV testing kits or PrEP supplies, or in fact, I want to say PEP as well, because if you're providing PrEP, you should also, we just had a discussion about this yesterday, also be capable of providing PEP. So how are the commodities supplied to these clinics? Maybe Gertrude, this is a question for you long-term for Zimbabwe. Do you see the how sustainable is this in terms of commodity and supply chain issues?
Okay. Maybe like we had that challenge, maybe there was sort of like maybe a challenge within our supply chain management. But in what is happening in Zimbabwe on the supply chain management, we are using for the family planning commodities like condom and all the other family planning products, we use the same supply chain management for ARVs and all that. So maybe it was just maybe a supply chain error in that facility. But when we are looking at our supply chain management in Zimbabwe, it's for both actually family planning and ARV medicines.
I'm just going to do one more question before we move to Josephine. I know this was just a short pilot, so I don't know how long did you follow the clients, and do you have any sense of the continuation rates on PrEP for those?
The pilot was for 6 months for Zimbabwe.
And did those who were initiated on PrEP typically return for refills?
Some of them, they were actually retaining, like what we've actually done even a cohort analysis, not only for our pilot, but for other areas. How long do people usually after the first month, they will retain, and after the third month, they will retain. But thereafter, we are having some challenges. But we've realized that our clients, they stay maybe on PrEP, like maybe for 4 months, depending, and then the serodiscordant clients, they stay even more than 4 months, like we've seen like others, they are even staying for about 6 months, 12 months, or especially the serodiscordant couples.
Okay, thank you. I think we're going to move on, given the time, and let's hear from Josephine on another study, the POWER study, that has actually been evaluating PrEP delivery and family planning clinics over the last several years. Josephine?
Thank you all for the opportunity to present on behalf of our team. I would like to talk about integration into family planning clinic located at Jaramogi Oginga Odinga Teaching and Referral Hospital, a public MOH Ministry of Health run facility, and the Kisumu Medical and Education Trust, a private entity. Both are based in Kisumu. And let's move to the next slide. The prevention option for women evaluation research studies an oral PrEP implementation science, and it is seeking to evaluate PrEP delivery models among adolescent girls and young women aged 16 to 25 years at the 2 family planning clinic platforms that I've already talked about. We are testing whether offering PrEP in this family planning clinic would be acceptable to the adolescent girls and young women. And as shown in the map, we are at the shores of Lake Victoria. Look at the red, and which records some of the highest HIV prevalence rates in the country. The other sites that are doing this study, though testing different platforms, are Johannesburg and Cape Town. Next slide, please. Next slide. So I want to walk you through the process, what happens in the 2 facilities. For an entry point, you need to have the management, and we have the different management structures. They have to give permission for any work to be done. This is very necessary to minimize any delays in implementation or any distraction when staff probably
We lost Josephine. Josephine, I think you're on mute. Can you unmute yourself, or did we lose her line? Martha, do you have any recommendations? It looks like she's muted on the phone, on the screen.
She has two logins. One is muted and one is not muted.
I do apologize, folks. It is hard to get some of these connections through. Josephine's calling in from Kenya, so. Martha, why don't you work on that, and then I'm actually going to ask you, well, I don't know, should we open up the whole line? 99 people. It's a lot. I did want to comment. There was some question here
Hello.
about.
I'm here.
You're back.
I'm back.
Okay.
I've really been having internet problems. I'm
It's
very
okay.
sorry. So
Thank you.
I
Go
was
ahead.
saying that we've been planning for the trainings to impart knowledge on PrEP because already family planning was being offered, and this we do to increase their competency. We again look at station study staff who on daily basis do on-job training to the staff who are offering family planning, because we came in as people who were experts on PrEP. And we have been holding monthly meetings to share experiences and challenges. So this whole process is important because whenever you start a new study or you want to integrate a new intervention, like we are integrating PrEP into family planning, people have high expectations and they think there are benefits that come with the study. So we want to do a lot of these meetings to allay fears. Next slide, please. This diagram explains the shadow approach that we were using. When we went in, power nurses were offering PrEP. That was our main agenda. But when we went, the facility nurses were offering family planning only. So what happens is that once in the middle there, both power staff and facility staff, they work together and learn from each other. And after that, what happens is that now each independently are able to offer PrEP and family planning together. And all these are done under one roof. Next slide, please. I just want to show you, if you look at the public health facility, that is the JOTRH, there are multiple rooms. We have a HIV testing center just centrally put in any person who is walking in. If you want a family planning service, then you will be tested first for HIV. Then, because that room was small, that is why you are seeing an arrow pointing to the power PrEP room. That one is supposed to help to do risk assessment using the RAS tool, risk assessment tool. And we have another platform, the FTI clinic, which also offers PrEP. But if you look at the KMET on your right, we have family planning room. Everything is being done in one room. And once that is done, clients are sent to the pharmacy to get PrEP. And that has worked very smoothly. That is how we have been able to work up around this. Next slide, please. What are we doing? As I've told you and I've explained in the diagram of JOTRH, we created an annex room for PrEP assessment because that room was very tiny and there was no privacy. So when you want to do risk assessment, it becomes a big challenge. So we created another PrEP room just about a stone throw away, where we did counseling, risk assessment, and we were able to also dispense PrEP in that place. If you looked at the testing there, if someone walked in, because the staff who are there were able to identify a client and refer them appropriately, so we would also offer family planning in the other PrEP room that I talked about. We engage PrEP partners, that is ICAP, which is a PEPFAR-funded organization, and it supports HIV care and treatment at this facility. And we also want to know the community thoughts, their ideas on giving adolescent girls PrEP together with family planning. So we engage them a lot and hear what their thoughts are. We try to align the visits of those who are coming for family planning so that their visit dates are aligned to the family planning dates that we have. For a continuation of PrEP, we had engaged the Power Queens. These are young girls. They come and talk about their issues, and we have quarterly meetings, and through this they bring their friends, and they listen to the talks that are going on. And if some are interested, it is an approach for recruiting more girls into the study. Next slide, please. These are just the different pictures that we took for the areas where we are doing the family planning. The rooms are very tiny. We have utilized the different space, and we label PrEP. If you look at the left, the down picture, you can see PrEP label there, so that people who are walking in, any walk-in, can see where PrEP is offered. Next slide. Next slide, please. So what worked? What we have found working, go back to the other slide. What we found working was targeted, tailored messages on PrEP. We talked to them what PrEP is about, what the likely side effects are, and we also give them the option of bringing their partner in if they want to involve their partners. We do routine health talks, and in this health talk, we also add information on PrEP. If people have questions, we are able to address them. As I said before, leadership is very important, and supporting for any success. If you involve the management and they are supportive of the work that is going on, then you will achieve a lot of success. I'd already talked about the HIV testing, and what we found, because we had created an annex room, the nurses who are offering family planning were able to refer clients that they thought wanted family planning, had gone for family planning and wanted PrEP, so they would refer them to the PrEP group. Kemet is already receiving PrEP medication from the Ministry of Health. I told you that it is a private facility, and the Ministry of Health has all the tools that we are using to monitor PrEP uptake. And so we use things like clinic encounter form, we are using PrEP register and stuff like that to monitor the commodity and everything that is going on. Let's move on. Next slide, please. So we've also experienced challenges. The main challenges have been on waiting time, because if you saw the diagram I showed you about TRH, you go to different points. And so that can create a lot of time. And I've already talked about the inadequate space. We had knowledge gap. When we started, no one knew anything about PrEP, and so we had to do a training so that they were all at par. We have staff who believe that this was going to increase workload, and that is a problem. And sometimes some of the staff, the nurses, they feel that why should young girls be given family to take PrEP? So some of their attitudes keep the girls away. And then for the participants, we have a lot of myths and misconceptions. Some of the young girls give us contacts, they are very mobile, and they give us contacts of either their boyfriends or their spouses. So when we trace them, so that we are able to retain them, we find that probably they cannot be reached, and probably they've also not disclosed. And we have also stigma issues, and these stigma issues can be resolved if you are in a private and a friendly place. Next slide. So the lessons we have learned is that adolescent girls want a one-stop shop for HIV and family planning services. And the clinic should be flexible in contact hours. They should be able to be friendly the way they talk to the young girls, because that influences their follow-up and continuation of PrEP. So, and the other thing is trying not to be judgmental, and also flexible and able to align the visit date for follow-up purposes to reduce on cost and encourage them to come. And I've already talked about another big lesson learned is leadership involvement is key to success. When you don't involve them, they can be very disruptive. And finally, I want to say that the importance of STI and HIV self-testing cannot be delivered. It is potential for reducing on waiting time. Finally, last slide, I hope. I want to acknowledge all the PIs listed here, the study participants, the power staff, and the facility and the management where we are working, and the PrEP implementers, like ICAP have mentioned, and the study sponsors. Thank you so much. This has been frustrating.
Thank you, Josephine, and thank you for persevering in spite of the technical challenges. So we've had a number of questions that have come through. I'm going to share some of them with you. So one question is, how do you align the visits of family planning and PrEP with long-term family planning visits? So for example, if you have a client comes in and is put on Implanon, what is her follow-up with knowing that PrEP requires regular follow-up? Does she continue to come back for those PrEP visits at the 1 and 3 month sequence, or? Please.
So thank you for that question. I think it is very easy with the short-term methods, but that has been a challenge with long-term methods. However, even though our national guideline says that we give PrEP for 1 month and then they come back, we have tried to assess clients one-on-one, and if they have they have to take 3 months and they are willing and they are going to take their medication, we can always give them 2 bottles at once, so that when they come, they have fewer visits coming, because you cannot align the long-term method perfectly well. So there's frequent coming because they have to come on a monthly basis for monitoring.
And how are the clients reacting to that? Here's another question about hearing a little bit more from the patient or client feedback on how they like the services, PrEP services delivered through family planning.
Oh, they really love it, especially when when they come into a room and you are doing everything for them. You do the risk assessment in one place, you counsel them on other matters, even on family planning methods, because sometimes they share side effects, and those side effects, some of them are really not related to PrEP. Some of them are related to family planning. And so you go talking to them. They really like it when you have a friendlier area and a private environment, and they tell us through interviews that we have conducted. We have done qualitative interviews with some of the users, and through I talked about Power Queens in those meetings that we hold. They tell us and give us a feedback that they would really like continuing having PrEP delivered in family planning clinics.
So this is an example. You said this is a private clinic, correct, Josephine?
Yes.
So this is pardon?
The Kisumu Medical and Education Trust is a private clinic. It's a private entity.
So this is a more a well-resourced setting than your typical public health clinic.
Yes, yes, that is true.
So it's hard to get a full sense of
it is more of a youth-friendly clinic compared to the public health facility. You know that public health facility is a training facility for even students. So you have so many people attached in the room when they come. They are learning, and young girls don't like many people present. So we compare the public health facility and the other private facility where we work.
Yes. And so perhaps though we're getting a number of questions around retention and adherence. And I just want to start by reframing those. So we're trying to move away from the word retention with PrEP because it is that's more in sync with what works with in the treatment field. But given that there is going to be some normal cycling on and off PrEP with starts and restarts, we're trying to talk more in terms of continuation and cycling. And then in terms of the adherence, of course, you do need to take the pill daily during periods of risk for it to be effective, at least if you're a woman. There is now intermittent dosing guidelines for men who have sex with men, but not yet for women. So I'm just wondering if you could share something from the POWER study, Josephine, about what your adherence and your continuation and cycling looks like among your clients.
So adherence has been very good. When they come for their refills, yes, even in Kenya, we are using continuation. That changed from retention. I was just thinking of a study, but yes, we are using continuation. We have clients coming in on a monthly basis. What we noticed initially when we started, there was a lot of drop off at month 1 and at month 2, but at month 3, those who had dropped off were, for whatever reason they had given for dropping off, they came back and they still wanted to continue with PrEP, and they would come. And so when we are counseling them, we also offer them adherence counseling. Sometimes, because I talked about young girls are very mobile, one thing that they complain about is traveling with the bottle. The bottle is big and it makes a lot of noise. So one of the things that we tell them to do is put like cotton wool inside that bottle to stop them from the rattling noise that discourages them. And we can tell them to plan. Some of them use small like purse-like containers to put in their pills when they travel. So we encourage them to do that. And the Power Queens has also been a very good strategy where we reinforce adherence messages and tell them, they share amongst themselves what they do. So it has been they are hearing from PrEP users what they do, what their challenges are regarding adherence, when to take the medication and stuff like that. The reminders, who can remind them.
Thank you, Josephine.
But we've also been giving calls. We have been calling them just to let them know. We just call them and find out, how are you doing since the last time you were in the clinic? How are you feeling? How are you going on with your drug? Are there challenges? We call them before they come to the clinic. So that has also enhanced continuation.
So there are a number of other questions specific to the POWER study, but I'm going to pause for a moment, and if we can't get to them on the call, we will have you respond to them in writing with the follow-up notes from this call. But I want to turn over to Bwanilo from Botswana, who works with the Advancing Partners and Communities program. We don't have slides, but would like to hear some reflections on what the work is, what kind of work is being done around integration, including integration of STI screening and treatment in Botswana.
Okay, good afternoon, everyone. Am I audible enough?
Yes, great.
Good afternoon. Okay, my name is Bwanilo from Botswana, from Accelerating Partners and Communities Project. We do implement PrEP. We started in October last year. We are continuing, even moving forward. Our PrEP is implemented through the DREAMS program together with family planning. So what were our lessons learned when we started to talk PrEP? This was a new concept, more like giving ARV drugs to adolescents who are negative, as the Ministry of Health interpreted it. So one of the key considerations from the beginning was to ensure we are in a similar understanding with the Ministry of Health, the protocols, the procedures, setting up tools. But let's remember, family planning has been part of the system long before the project came into place. So we had to design screening tools that gets to integrate STI screening, family planning screening, and PrEP screening, such that when a community health worker meets an adolescent in the community, they can screen for all these services. So that was one of the things that we had to be sure the Ministry of Health understood it. We had to create demand for PrEP that is integrated with family planning together with STI screening. Either is for post-GBV survivors, other is for adolescent girls and young women under the DREAMS programming, such that when we go out to do demand creation, there's integration of these services. So our priority population for PrEP is adolescent girls and young women, and our priority population for family planning is still adolescent girls and young women. So we have seen this integration at our wellness centers. Let me take you a little bit back. When the project started, we have 2 wellness centers in 2 different facilities. These are trying to operate outside the normal public health operation, where you walk in and it's a clinic with adults. We are trying to create youth-friendly services that adolescents can feel free and come to and access the services. So one of the interesting things that I've picked from this, as others were talking, is how are we dealing with family planning and oral PrEP appointments? We have faced serious drop-off of girls at month 1 and at month 2, especially when they feel that their issue is, they feel they are experiencing more side effects, or they feel they are no longer at the risk of contracting HIV. But dropouts were more with PrEP than with contraceptives, which we had to do a more case management approach, such that we do follow-ups at community level. We do PrEP reinitiation for those that want to continue with PrEP but had other reasons at community level. So even there are follow-ups. But it's slightly not easy for long-term family planning methods, especially that our PrEP protocol in Botswana is at 1 month, they have to come for check-up with the doctor, and then you can start the 3-month supply. So you may find they come for the first month checkup, they come after 3 months, but at the end, they feel it's not matching what they want, and it takes long for them to access some of those treatments. So what have we seen working for the other part is the integration of PrEP into other services that are not either family planning or STI management, like where we do treatment initiation. We had gone through a period where we're going so much into the community to do community initiation of treatment. So for those that were discordant couples, we'll initiate them on PrEP right at community level. So these have worked so wonderfully for us. Even community initial screening and eligibility for PrEP and any other clinical service, that model has worked for us. And we have gone into activities of using social media to create demand for both PrEP, STI management and screening, and family planning services. And it's these methods that have worked for us to be able to have girls who will be interested in PrEP. Thank you.
That's very interesting, Bonilla. I'm wondering, could you tell a little bit more about your PrEP screening and initiations in the community?
Okay. When we started October last year, the Ministry of Health, together with implementing partners, had to set and develop a screening tool. So as the community health workers go on the field to do demand creation, so they will teach girls on what is PrEP, what is family planning, what is STIs, and then sit with the girls to ask a set of questions. And then the girl will say, okay, then I think based on my risk perception, I am interested in PrEP. So the girls will be, that will be the initial screening, and then the girl will be taken to the facility or to the community nurse to do further screening of eligibility for PrEP, and then the HIV test and all other bloods that have to be taken. That was our screening. So it's more like 2 phases of screening where it's just a set of questions by the community health worker and then being transferred to the community nurse who was mobile across the 2 districts to reach the girls where they are at their own convenient time. As it was said from the power study in Kenya, they are highly mobile. They'll make all quad appointments that work for them. So we had to reach to them where they were. So what was the next part of the question?
No, that was the question.
Okay.
I think what we're going to do is actually open the lines up. So this could get interesting, but we have time today, and there are a lot of questions, and I'm almost having a hard time figuring out which one to go to next across all the speakers. I'm also, one of the questions has to do with KP populations and, you know, to what extent they would access PrEP through family planning services, which obviously would make sense for female sex workers, I think, but obviously male contraception has not become a major family planning method yet. So aside from condoms, I'm just wondering if anyone actually, either our panelists or our attendees, want to comment on KP populations and PrEP integration, either with family planning or with STI services.
Hi, this is Martha. I'm unmuting the panelists, or the attendees, but if you can answer that question and you don't see an unmute option, raise your hand and I will unmute you immediately so you can answer the question.
Can I answer the question?
Hi, can you hear me? This is Chris.
Yes, go ahead.
Yeah, so I just wanted to respond to the question regarding KP. So I think generally what matters to, and in this case, we're talking mainly about the female sex workers because they are the ones that require, you know, family planning services. The most important thing to them really is providing very friendly services and the ability of providers to be able to provide competent services that meet the needs of the female sex workers. So in terms of being able to access services from family planning clinics, I don't think there's any major issue as long as the capacity of the service providers have been built, particularly in being sensitive to the needs of the key populations and to be able to address, you know, them correctly without providing any, without stigmatizing or discriminating against them. So from my experience, sex workers or KPs in general are comfortable receiving services from wherever, as long as those basic things have been addressed appropriately. So within our program, we're also looking at how to integrate PrEP into family planning, as well as making sure that those who are accessing PrEP from our drop-in centers are able to access family planning services. But what we've been working on over the years is building the capacity of the providers, sensitizing providers, and making sure that stigma-free services are what they're focusing on, not necessarily discriminating against sex workers, but just making sure that whatever services they provide to members of the general population are also provided to the key populations without any stigma or discrimination.
Thank you, Chris. Any other reflections on that point? I think another big topic that has come up through the questions, and is part of the reason I think we're interested in integration, is stigma. And so there, you know, when PrEP is delivered in combination with HIV testing and treatment services, it gets very strongly affiliated with being HIV positive, which still sadly has a lot of stigma associated with it in the community. And so one thought is that by having PrEP being delivered through other service delivery points, public health facilities, family planning, STI clinics, maternal child health clinics, ANC, et cetera, that this will destigmatize HIV prevention and make it more of a positive normative step for someone to consider when they're at risk. So I am interested in hearing thoughts from those on the panel or others around how what have you observed with your efforts to integrate PrEP with other non-HIV treatment services? How has that affected stigma?
Hello. Okay. From our side, the stigma made a very little contribution to none to the reasons for dropping out of PrEP. It was just like 1%. Majority of the issues were the partner or parent upset or rejecting PrEP use. Because for us, our centers are more like wellness centers that are not necessarily for treatment or for ARV or for specifically for ARV clinics. So how we dealt with this part of parents or partner upset or rejecting PrEP use, we did a case-by-case management approach where for girls who will come in, want PrEP, and they'll say, my parents will not agree, we'll have that parent-daughter education on what is PrEP. And this has worked for us. But the stigma part, when you have raised awareness and provided education, people reception of PrEP was very good.
For Zimbabwe, the integrated side, which was providing both treatment, HIV treatment prevention, and family planning, we realized that we had actually more clients which were coming to that integrated side. So maybe looking at that, we realized that maybe there was really no stigma actually on whether we are providing services within the treatment, HIV treatment sites.
Yeah, it might actually get at the point that was just previously raised about the support from the partner or family. They may be more supportive of going to get a HIV prevention service if it's in a family planning or public health setting rather than a HIV treatment center. There was a comment from one of our colleagues on the chat about MSM, and it's true, we are not meaning to leave men who have sex with men out of the equation here, but it's just that this session today happened to focus on the family planning integration But I do think thinking about integrated delivery models that would serve men who have sex with men, or as well, that would not be as stigmatized as going to HIV treatment center, are important.
Can I comment?
Yes, please.
I just wanted to say, in some of our clinics, the family planning clinics, we've been having a few female sex workers coming for both family planning and PrEP at the two facilities that I've talked about. And I don't have the figures right now, but I could share that, how many girls are, but I think they like coming for their family planning services there. In Kenya, when PrEP was launched, most of the facilities that were offering PrEP started in HIV care clinics. And that is why a lot of stigma was around. If someone saw you with a bottle, they thought probably you were HIV positive. And that is where stigma was. And if they did not disclose, and this also forms some of the reasons why some of our clients were dropping off initially. Some of them separated. They were more aware and identified their risk. They felt maybe if they had multiple partners, they had now less, or they had gone for HIV testing, and now they knew their HIV status. So some of that made some of them drop off, and some of them had misconceptions on side effects. And because we did not reimburse them when they were coming for clinic. And so for a few dropped, they dropped because of the cost of coming to access PrEP in a family planning clinic. And I think the female sex workers, again, they like the clinics because they are private and confidential.
Thank you so much. So I think we're at the hour. We have a lot of questions, and as usual, we will do our best. We will ask our panelists to help answer these questions in writing, at least some of the big ones, and we will provide a resource sheet and a link to the webinar, so that should come out in a week or so after this. So please look for that in your inbox. If we could move to the next slide. Mila, I just want to highlight for everyone, continue one more, again, and then click a few so it all comes up. I think we have our next webinar is on November 21st, and this is going to be on target setting and costing with PrEP. And that will be our last virtual webinar for this calendar year, and then we will begin again in January. If you have specific topics you'd like us to address, please feel free to send them to us. Also, we are going to be considering for next year, do we need to change the date or the time, how to make this more helpful and useful for implementers on the ground. That's the whole goal. So we really do welcome and appreciate your feedback, even if it's constructive criticism. And then finally, I'll just mention on the next slide, I believe, Mila, is that we do have a face-to-face meeting taking place in Malawi in a few weeks. And we actually have quite a few people registered, but if this is something you are planning to come to, please do register this week. We are very much nearing capacity, and actually if you have registered and are not planning to come, please let us know as well, because we are just trying to make sure we have our numbers right. So we thank you for joining today, and I wish you all a good evening and good day. Oh, and there's a poll. Sorry, quick, launch the poll. So all you have to do is click one of these, and then we're done. And also just a big thank you to our speakers and panelists today. Much appreciated.